Hey guys, this is our second webinar series of the Healthcare System and Medical Education Across the Globe. And this week we have Africa region representing here today with Yasser from Kenya, Ibrahim from Sudan, and Bismarck from Ghana. He's not here yet, but he will come in a while. So as last week, we have here under the screen, we have in the description of YouTube the link for the students to fill in to get a certificate. Remember that you must watch 3 of the 5 webinars to get a certificate. And you can fill it anywhere during the webinar, but not after. When it's done, the forms is closed. And also, you can always send questions on the link we have also in the descriptions of YouTube, so we don't give a lot of comments in the live chat of YouTube and don't get confused. So please send all the questions you have. You can send any time of the webinar, but send in the Google Forms we created. Okay, thank you. And now we will start with the Brazilian presentation today again. So okay, I guess you can all see my screen. And we will start the Brazilian presentation so everyone can discuss, and maybe the other countries don't know about our health system. And well, that's also to them to get to know. So I will start very quickly with our part, just so everyone can see like Brazilian system and medical education. Okay, so in Brazil, we have we call system SUS, that is Sistema Único de Saúde, or in English is the Universal Healthcare System. It's public and free, and its principles are university, equity, and integrity, which means that everyone in Brazil have the right to be assisted. So even if you're a foreign student or people, if you're not from Brazil, but if you live here, or if you are here visiting, traveling, you're able to use the SUS because it's like for everyone. So for people that I visit, you cannot use the primary healthcare because that you need to live here to use it. But if you need emergency, like if you broke your hand, like someone, you can go to the hospital and they will attend you. They will do everything they can, and it's for free. Like you're not leaving the country with a big bill to pay because you get sick. So it's all free, and they distribute the efforts according to the local necessity. So if one city needs more attention than the other, they will have more places of the basics healthcare or more hospitals. They will have more of what they need, so everyone can like have the right to be given the right attention, and to provide adequate support to everyone and what they need, not give support to something that no one needs in the region. Okay, so and every person must be seen as a whole. So the SUS, they try to not only treat what the person are feeling, like if they're sick or if they have some symptoms, but they try to take care of the patient as a whole. That's why we really focus on the primary healthcare, like to the basics. So try to find out before he's sick, or try to prevent to be sick. So that way also we believe that we increase the amount of money used taking care of the sick. So that's good. And in order to do so, SUS is not restricted to the healthcare system, and they have a major role in articulation actions with other fields like education and work legislations. So in our Brazilian legislation, they have like a lot about SUS and what SUS can do and all the rights of the SUS and everything. And people like the community can also be part of all the decisions. I will explain this like in the next slides. And we also have education, like try to implement the health system also in school, so you can give the education for the children as soon as possible of what, like the ways that they can prevent to be sick or something like that, and to ensure health promotion and prevention. So the healthcare system is organized in three instances here: is the national, state, and municipal authorities. They're all responsible for managing the finances, the assistance, which means it's a joint action. So the national government, also the state government, and the municipal government, they give part of the money to the seus to implement the seus locally. So yeah, so all the three, they must give some money, part of the money they receive, for improve the system. And the healthcare hierarchy is also divided as three organized levels. So is the primary healthcare, which is family medicine; the secondary, which is ambulatorial. So is when people need something with cardiology or endocrinology, some like more specialized help. And the tertiary level, that is hospitals. The primary assistance is organized in basic health units, what we call UBS in Portuguese, and that encompass with the majority of the city's extension. So in this map, you can see here, for example, all the colors here represent as a whole a city, and each part of the city, they have one color, and this color represents that this part of the city is like one of the UBS in Brazil take care of this. So for each color, they have one UBS, and they have a lot of groups with at least one doctor, one nurse, physical education, and I will say more what they have in the next slide. And they will divide the population of this region in the groups, so everyone can have the same amount of families to take care. Every UBS is structured with a multidisciplinary team, with a doctor, a nurse, a dentist, and a community health agent, and also they serve as a major entrance door to the whole health system. So, like, it's not how it is indeed, but you're supposed to be first in the primary level, like you should be like in the UBS before going to the hospital. Sometimes it's easier to just to go to the hospital to have like an emergency consult or something, but usually like you need to go to the basics to like go to the secondary healthcare or to the hospitals. And in order to do so, every city is divided into sanitary districts that have power to regulate their own primary healthcare, defining the distribution of UBS in the territory. One of the most important features of SUS is the popular participation. Everyone can participate on the system's decisions, like everyone that lives like in my city, I can and I should participate of the conference that they have with health councils to be part of the decisions, like what they will improve in my city or in my community, so I can have a voice and a vote to vote what I think is the best for my community. And like if they decide, oh, you should have one more hospital here, and like is that really important, or like you can decide if what your community needs, so they can do it and improve it. And every person can take part. You don't need to be like a doctor or and like if you just live in the community, you can go to the meeting and have vote and participate in all the discussions. In this way, everyone can help by suggesting the strategy and controlling and evaluating the executions of health policies, such the UBS level and reaching to the national sphere. So even to the hospitals and maybe some regulations in our governments or something. And now I will speak a little bit about the medical education in Brazil. So we have the medical course here is 6 years and is divided in 3 blocks. So basic cycle, clinical cycle, internship cycle. The first 2 years of medical school is the basics, and it contemplates areas that is common for the most of the health science course, such as anatomy, biochemistry, and those kind of basic cycles. And clinical cycle is the third and fourth year, and divided into medical departments like cardiologists, pediatrics, endocrinologists, and all the subspecialties. So when the students can combine theoretical classes with hospitals and ambulatories, so you learn the theoretical thing of their facility, and then you go to practice, and you have like a mix of both to learn who properly assess the patients. And the last 2 years are the internship cycle, and they're exclusively practical, like you almost don't have theoretical classes. So when the students take part into the hospitals and emergency, and we rotate in areas like pediatrics, gynecologists, and obstetrics, general surgery, internal medicines, like all the specialties, public health, and yeah, that's basically all the areas we go. And some universities also include rotations in mental health hospitals, so but not all of them. And others have programs in rural zones, and that's really nice. Like I don't have my university, but I heard that the rural internship is like really amazing. And those rotations are not remunerated. We don't get any money for like basically act as a doctor, but we are not. So we don't get paid for that. It's obligated for us to graduate. Uh, and we have an exams at the end of each area you rotate just to graduate, and then we graduate, and we have exams to go to the residency, and that's it. That's Brazilian medical education health system. So thank you, and now I will stop comparting here, and I believe Ibrahim can start his presentation.
Hello, everyone. Can you guys hear me?
Yes.
All right, perfect. I'm going to wait for Juliana to share the screen.
It's on.
All right, I'm just waiting for it to show up in my screen.
I think it's on already.
All right. Yeah, I just saw it. Thank you so much. First of all, I'd like to start by thanking DENEM Brazil for giving us this amazing opportunity to speak about our healthcare systems, our medical education in all the different 5 regions of the IFMSA, the Africas, the Europe, Asia-Pacific, Americas, and everything, basically. I believe this is an amazing opportunity for a lot of learning, and through this webinar, we can learn a lot from what we present to each other and from our experiences and what we have in our countries. So I'm going to start. I am Ibrahim Mejdi Birkia, the current Medicine Sudan Nori for the term 2019-2020. And I'm more than delighted to be here with you guys today, talking about the healthcare system and medical education in Sudan, which is basically just going to be a small overview. I'm not going to speak a lot about the matter, because if I start speaking about medical education and health system and hospitals and stuff in Sudan, I don't think that I'm gonna stop talking. So yeah. So next slide, please. All right. So before I start speaking about the health systems and the medical education and the curriculum and everything, I'd like to give a small introduction about Sudan and where it is, the demography, the socioeconomic situation at the moment, where we stand, what we do, the different cultures we have, and most importantly, our history, because the Sudanese history is a very important part of what makes the original healthcare system today and the medical education system and the universities and the hospitals, the public sectors, the private sectors, and everything. So our history has been a huge role in creating what we have at the moment. So next slide, please. This is a picture of Sudan, Sudan, the capital city. This is the Nile River. It's a very beautiful country, of course. So the demography and the socioeconomic situation. Juliana, I think you're on to the, yeah. All right, perfect. So when I want to speak about demography and the socioeconomic situation, Sudan is currently the third largest country in Africa. Less than Togo was the largest country in Africa and the Middle East. But as you know, during 2005, there was a separation between Sudan, North Sudan, and South Sudan. I'm currently speaking to you from North Sudan, of course, from the capital, Khartoum. And as we separated between North and South Sudan, we became the third largest country in Africa with a land area. I'm sorry, I'm just going to zoom my face a little because I'm reading from the screen. It shares borders with 7 countries, including Egypt, Chad, Libya, Ethiopia, Eritrea, Kenya, and a lot of South Sudan, of course. And it shares borders with all of these countries. And we also have a huge coastal line along the Red Sea. Total population in Sudan currently counts around 41 million people in Sudan at the moment. You can see the exact number here on the slide. Sudan is a multiracial, multicultural nation distributed along more than 12, actually, at the moment, we have around 18 states and 184 localities. When I mean locality, I'm speaking about like let's say 5, 6, 7 cities that are grouped next to each other, and we call these a locality. Sudan is a middle income country with a GDP product of around 1.9 K dollars with an annual economic growth rate of 2.3%. The reason why I wanted to speak about this side is when you want to speak about the health system and the medical education in a country, you're supposed to give a good introduction about the country and what it does and how everything goes in that country and what made the current situation look like this. So next slide, please. If at any moment you guys cannot see me or hear me, please just let me know in the chat section below. So as I just told you before, the history of Sudan is very rich in terms of events and colonization and different cultures, different tribes, different languages and religions. It's a very rich and a very long history. But the most important part in the Sudanese history is the British colonization. During the last century, Sudan was colonized by Britain, you know, as part of that amazing timeline of Britain, Italy, and France when they were colonizing a lot of the African regions at that time for like economical interests and business and these things. So this is basically a small demonstration. These are like old portraits. The upper picture is during one of the battles with the British Army. The Sudanese gained their independence, and the picture, the Sudanese army at that time, they used camels instead of. So the British colonization, please, Juliana. So when did it happen? It happened during the late 1800s from the last century, and Sudan gained its independence during January 1956. I cannot see the slide, Juliana. Okay, yeah. So, yeah, as I told you, it happened between September 1998 during the late 1800s and until January 1956. And the reason is because Britain wanted to protect their interests in Egypt. Italy and France started seizing big parts of Sudan, which was a huge threat to Britain. Take apart Sudan as well at that time. Was the impact left after the British colonization? Has its positive impacts and negative impacts, but the British colonization in terms of new infrastructure, new railways, roads, there was an introduction of the healthcare system very similar to the British system at that time. A very well-known universities in Africa and the world is the University of Khartoum in the bottom right corner inside. University of Khartoum, which was founded in 1902 as Gordon Memorial College. And I currently go to this university, by the way, I say so. And they also introduced the civil service, mail system, agricultural projects, and a lot of things that gave Sudan and gave Africa a lot of good financial stability and sustainability in terms of a lot of projects, basically. So next, please. Yep. So when I want to speak about the healthcare system in Sudan, there's a lot to say, but as I told you guys, I tried to keep this as short and as efficient as possible. And I wanted to relate it to the history of Sudan because, as I told you, it played a huge role in the current healthcare system and very diverse and a very rich healthcare system in terms of the policies involved, in terms of the systems that we use, in terms of the way everything is managed. I'd like to say that the healthcare system in Sudan recently has developed a lot as there was an old government that was overthrown like 2 years ago, actually last year. And the current new government is working on developing and further building up the healthcare system to make it even better. So next slide, please. Okay, so the healthcare system in Sudan, as you guys can see in the slide, is mainly run by the Federal Ministry of Health. When I say federal, I mean that it's a national Ministry of Health. It's running the whole country. But that's not the only level of governance. We're going to know more about this in the next slide. So it's mainly run by the Federal Ministry of Health, but it is greatly influenced by national health policies, or let's say NHPs. National health policies in Sudan, they aim to identify and address determinants of health through adopting a multi-sectorial approach. You guys must be asking yourself why a national health policy would be better than the Federal Ministry of Health in terms of like managing the healthcare system, the patients, the doctors, the pharmacists, and everything. And that is because when we actually have a policy that is national, we're going to allow more than one party to give their input in the healthcare system, as in not only doctors or not only the government has a say in the system, but doctors, medical students, nurses, pharmacists, lab technicians, scientists, politicians, and everyone can have a say in the current healthcare system because the healthcare system needs a multi-sectorial approach, especially in a country like Sudan. It's a very big country and there's a lot of different mentalities and different people and different cultures. So we need this sort of policy. And these national health policies, they invest in the system to achieve what is known as universal health coverage. I think we all know what UHC is or what universal health coverage is. And most importantly, it has to and a timely manner. Basically, the healthcare system is currently aiming to do this in a short time and to make sure that it is sustainable and does not end in years maximum. Next slide, please. I'm having problems. Just 1 second.
Ibrahim, you're there? I think he's trying to enter again because he had some connection. Okay, now perfect. You're back.
Hello, everyone. Sorry, I just had a little technical issue, but I'm back now. So, can you hear me?
Yes.
So, perfect. So, if I want to speak in depth about the Sudanese healthcare system, it is a decentralized system. When I centralized, I mean that it is not only run by one person or one institution, for example. We have three levels of governance. The second level of governance is the state, and the third one is the locality. So, federal, state, and locality. Next slide, please. This is a small picture of the map of Sudan in Africa, in case anyone doesn't know where Sudan lies in Africa. Okay, so I'm guessing you guys can see me now. Yeah, so we have, like I told you, we have three levels of governance. The first one is being the Federal Minister of Health, federal. The second one is the state, and the third one is the locality. So if I want to speak more about the Federal Minister of Health, it's basically responsible for policies, policy making, planning, legislation, financing, um, coordination, external presentation. It's basically like an NMO. You know what an NMO in the IFMSA is like, just like that. So it's basically responsible of coordination on a national level, and it takes charge and it's responsible for the ministries that are the state ministers of basically. So yeah, planning, legislation, coordination, participation, capacity. The second stage, which is basically operational plan, real life implementation, capacity building, secondary and rural hospitals, as state in contact with the hospitals in the cities and in different states. Like I just told you, it has around 18 to 19 states, actually 18 states. Yeah. So these states health are responsible of the healthcare system in each state individually. And the last level of governance is, of course, the locality, which is the primary health, maternal health, vector control, tropic, and these things. They're basically in charge, or they're in touch with families on a very close level. Next slide. Um, it looks like I have some connections so far and from the systems all around the world. Okay, perfect. So I have more things that I want to mention in terms of provided by the Ministry of Health, the Federal Ministry of Health, and the State Ministry of Health. But we also have other providers, such as the National Health
Ibrahim, you there? We're having some internet issue, but it's okay. He's using his phone, so it's not the best internet connection. Well, I think he's coming back, so yay.
All right. Hello everyone. I'm back to
Hey,
the broadcast. I apologize for the technical issue once again. Woo! So yeah. So I stopped at the universities part. So as a very important medical education is have your own. Um, so this also benefits the population as a whole. Of course, I think all these sector, the private sector in terms of the healthcare systems. Speak about the geographical cover. Um, the geographical coverage of the student population is, according to the most recent statistics, in the 2011 to 2016, which is a great progress and Sudanese healthcare system because we usually have problem healthcare system is the central capital city and the big Sudan, but the marginalized are included. They travel to big cities in order to receive their healthcare services. So the health currently covers around 95-97% of that. This is the current situation. Okay, so while I wait for the slide to go to okay. National policy. The goals is shift the national health policy or an NH. So go when it comes to a national health policy rather than a mini we want to focus on an integrated and a coherent, a coordinated policy making process that all different financial backgrounds, different cultural backgrounds, and the mission behind the national policy is behind this. I don't spend much time in this slide, so we can go to the next one. I don't know if you guys are going to share the material with the participants. I'd really appreciate if you do, in case you want to read more deeply when it comes to these. Next slide. All right. I wanted to dedicate this part of the webinar, of my webinar part, to say a huge thank you to all of our healthcare pharmacists, lab technicians, scientists, NGOs. Everyone has been working really hard over the past couple of weeks, and we have lost a lot of our dear doctors and healthcare providers when fighting this COVID-19 pandemic. So a huge thank you to all doctors in Sudan, Africa, Europe, America, Asia, everywhere basically, because I believe that without our doctors and medical students, we wouldn't have been able to fight or come out with the least amount of loss or deficits in terms of lives and economies and stuff. Thank you so much to all doctors. Next slide, please. So this part is about the medical education system in Sudan. I hope that you guys are going to benefit from it and find it interesting compared to the medical education system in your different countries. Next slide, Juliana. Okay, so the medical education system in Sudan varies from the traditional British medical education system, where the first years are pre-clinical or basic sciences, such as anatomy, physiology, biochemistry, pathology, and these basic subjects, followed by a clinical training in the last years. By the last years, I mean the last 2 to 3 years. I'm going to speak in more detail later, which is basically an integrated medical education system. This is the second option. So it's either the first traditional British system that the British people gave to us around 50, 60 years ago, or the new integrated, or as they call it, the American system. It's more coherent and integrated between basic subjects and clinical studies. So the body or the institution that regulates the medical education in Sudan, especially for the undergraduate level, is the Sudanese Medical Council, known as the SMC, while internships, which are given to the postgraduate doctors, are regulated by the Federal Ministry of Health. Next slide, please. In this slide, this picture is a picture from the University of Khartoum. It's one of the oldest universities in Sudan. As I told you, I study in this university as well. And the courses in the medical curriculum in Sudan range from 5 years to 6 years, depending on the designated university or which university do you go to. For example, do you go to University of Jazeera? Do you go to University of Milan? Do you go to University of Medical Sciences and Technology? Do you go to University of Gadarif? Depends on the university. So some use the 5 year course, some do the 6 year course, but 6 year is the maximum course. And Sudan has over 50 medical schools with varying curriculums and varying teaching strategies. So we have 3 cycles. There's the basic cycle, there's the clinical cycle, and there's the internship cycle. So when we talk about the basic cycle, it's basically programs differ between in the first 3 years, you either take the pure basic sciences or integrated system approach coming from the respiratory system, musculoskeletal system, and these systems. This is the basic cycle, basically. Next slide, please. And number 2 is the clinical cycle, of course, which is during the final 2 or 3 years of clinical training, pediatrics, gynecology, obstetrics, general surgery, subspecial part of the medical curriculum, as people are usually very bored of the basic subjects like pathology and immunology and anatomy and these boring subjects. But clinical is usually very interesting as it contains a lot of interactions with the patients and doctors and nurses and all of the healthcare providers in our beautiful teaching hospitals. And the Sudanese population is very known for their warm blood, and they're very nice and welcoming to everyone. And even the patients are usually making jokes and telling you stories, unless they're of course. But other than that, it's really fun, the clinical practice of that. Next slide, please. Okay, and once you're done with the clinical cycle, you have to undergo what is called as a public health course, or a community medical course, which basically focuses on all of the public health issues in Sudan and how to deal with them. The university sponsors trips to rural areas like far villages and far cities where there is a less developed or less economically developed healthcare system in order to be able to deal with. It's usually a very fun part of the medical curriculum in Sudan. I just tried to put like a little break in the webinar. These are like two pictures from Sudan. The picture on your left is a picture from the capital city, Khartoum. This is the Nile River. It's the longest river in the world, and it's the only river that goes from south to north. And there's a couple of buildings from the capital city. On your right is a mountain, a group of mountains, and this is a picture from one of our exchange groups that we received last year. This is an area in northeastern Sudan called Port Sudan, and people usually go there to like for the Red Sea diving, snorkeling, mountain hiking, and a lot of fun activities that Sudan offers at that part of the country. So it's a very diverse country in terms of like culture and social programs and people and populations and yeah. So next slide, please. The last part of the medical education in our system is the internship program. As I just said, our medical education. It is basically a 1-year clinical training program that you take after you graduate from the university in areas of pediatrics, once again, gynecology, obstetrics, surgery, and internal medicine. And these internships are paid by the Federal Ministry of Health in all hospitals, and all of the progresses, the reports, and files are also reported to the Federal Ministry of Health. This internship is mandatory, as in it's compulsory, and if you do not take this internship training program, you're a system. I hope that everything is clear so far. Next slide, please. Yeah. In addition to also the three cycles that I've just mentioned, we also offer the education system here offers a lot of extracurricular activities such as student exchanges, like the IFMSA exchanges, and more types of exchanges like professional exchanges, research exchanges, like the ones that we all work as part of course, and even national exchanges. We also the universities also offer medical missions like I just told you about the public health and the community medicine courses. A huge part of these courses is the medical missions, where students actually have to go to rural areas outside the capital and deal with the underprivileged populations. Trainings, researches, and all working groups with deans in the faculty and doctors and heads of departments. So these are all parts of our extracurricular activities that are offered by the medical educational system in Sudan. Next slide, please. Again, I think by now I reached the end of my session or the end of my part of the webinar. I'm sorry. These are just pictures from Sudan. This is the Nubian pyramids in Sudan. To the right is one of the well-known mosques in Sudan also. So a lot of our people who come from outside like to visit these areas and take pictures and try the amazing Sudanese food there. So you guys should come to Sudan very soon, either on holiday, on exchange, or anything. We'd love to have you in our country to experience a lot of the amazing cultures and the amazing educational systems. Next slide, please. Thank you so much for paying attention to this part of the webinar. I hope that you guys benefited from the Sudanese healthcare system and the medical education system that is offered in Sudan by the different Ministry of Health, universities, faculties, and government, of course. Thank you so much for your time, and au revoir. Ma salama. Ma salama is goodbye in Arabic, you guys, which is the official language in Sudan. Thank you so much.
Thank you, Ibrahim. It was really nice. So thank you. Like all the photos of your presentation was amazing. Like I really want to go to Sudan right now. It's really nice. Thank you for everything. So yes, sir. Do you want to go next, please?
Yes, let me just share my screen. I hope you can see my screen. Can you see my screen?
Yes.
Okay. Hi, everyone. Thank you very much, Ibrahim, for the fantastic presentation. I learned a lot about Sudan's health and medical education system. Thank you. Hi, everyone. My name is Yasser Hamza. I'm a Leo from Msake, Kenya, Medical Students Association of Kenya, and I'm so glad to be here to educate you about the country that I really love the most, the country that is close to my heart, Kenya, and the country I'm really proud to be a citizen of. And to just share to you our health system and education system as well. So basically, I've managed to get to today the two mottos of our NMO and the health system, which is nurturing the profession and improving health service delivery here in Kenya. So welcome to this amazing session. Yeah, so I'm just going to start. This is what our presentation will be covering today, just an overview of our health system, education system, and an overview of Kenya. And today we're going to learn also 3 Kiswahili words, just a plus point. So I'm going to start with the first one, which is jambo. Jambo means hello in Kiswahili. Kiswahili is the national language spoken in Kenya. So wait for the next 2 in the upcoming slides. So jambo is the first one. So just an overview of Kenya. So karibu Kenya, this is the second word, which means welcome to Kenya. So before I get into the whole story of health systems and medical education system, it's always good to understand a bit of the background of the country, even just to understand where Kenya is. So Kenya is a country, a beautiful country in East Africa. As you can see, Kenya is divided into 47 different counties. So counties is just keep that word in mind because I'll be mentioning it a lot. So the counties is just like the way the US is divided into states or Japan divided into prefectures. Kenya is divided into different counties, and we have 47 different counties. And I'm right here speaking from Nairobi County, which is the capital. Yeah, and we have a population of over 45 million Kenyans. Yay. So a bit about Kenya. Our beauty. So this is, as you can see here, this is the big 5. We are known for our big 5. This is the animals that you'll actually see living in their natural habitat when you visit Kenya. So this is a must-see. So the lion, the rhino, the elephant, the buffalo. So this is the big 5. We are known for it. This is our beautiful culture known as the Maasai culture, which a lot of tourists actually come to appreciate. And it's a very nice pastorous culture, and it's really beautiful as well. We are also known as one of the huge exporters of tea. We have amazing tea. So if you ever get to meet me or come to Kenya, you must try their tea. And we're also known for our beautiful beaches and the coastal life as well. So that's just a bit of background about Kenya. Now back the Kenyan health system. Yeah. So the Kenyan health system, so overall, we're going to divide it into majorly 2. So there's the public health sector, which is mainly the system itself, and there's, of course, the minor part, which is the private health the private sector, which is mainly to fill in the gaps of which the public health system has actually left. So, yeah. So this is the public. Let's talk about the public health sector. So our health, when it comes to health systems in Kenya, we start with our policy for 2014-2030, which has a goal of attaining the highest possible standard of health in a manner responsive to the needs of the population. And the policy mainly focuses on 2 main areas, which is realization to the right of health and devolution of health. Just like in Sudan, our health system is very decentralized, and this was after our new constitution in 2010, which empowered the different counties. So remember, I had mentioned that Kenya is divided into 47 different counties. So what happened was, before a long time ago, it was a centralized system. So basically, the national government had control over all the health in the 47 counties, and that was unfair. There was a lot of politics, corruption, unequal distribution of budget of money to the different counties, and a lot of people were suffering because of they were not receiving. There was unequal distribution of funds and budgets. So the devolution basically is quite a hot topic when it comes to the Kenyan health system, and it's the one that basically empowered each of the 47 counties in order to be able to carry out their own decisions when it comes to health systems in each of the counties. So each county has a government, and each county has their own now health system which they actually manage. And so the whole point of the devolution or the decentralization was to empower the counties to be able to control or have power over the health system, right? So it's the expectation of the whole devolved health system was to lead to improvement in efficiency of service delivery, stimulate innovation in the wider sector, improve access to, and equity of available services, and promote accountability and transparency in services. So our health system is decentralized, and yeah, so that's the whole, rather than it being centralized, and now more people have access. However, this is always a controversial topic when it comes to health system in Kenya, because there's some research that shows that the decentralization has failed or did not work. However, there are also some other literature that supports the decentralization. So it's a very controversial topic here in Kenya. This is what makes our health system. So we have the building blocks that this forms our foundation of the healthcare system. So from leadership and governance, service delivery, medical products, financing, health workforce, and information, all lead to an ultimate goal of improved health status, in order to also, which is also the ultimate goal of the healthcare policy here in Kenya. And equity is very important, especially because we are all trying to achieve universal health coverage. So I'll take a bit of time here. So this is healthcare service delivery here in Kenya. So as you can see, my pointer here, the pyramid, this is basically a pyramid system that was there, and it's still there partly, and was changed now on the right to 4 tiers or 4 levels. So basically, for someone in a community who wants to seek healthcare, he will have to climb up the ladder depending on the complexity of his health, from level 1 all the way to level 6. So you can see the distance that one has to travel or one has to achieve in order to achieve a proper quality healthcare. And however, this was then later on reduced to the 4 levels here. And like, for example, in the level 2, tier 2, we had the level 2 and 3s, which is now the dispensary and the health centers were combined because of the services they produce are similar. And also level 5 and level 6 were combined because the services they did produce were similar. And this was also to reduce the, is to improve accessibility for every Kenyan to healthcare, yeah? So Kenya's healthcare system is basically structured in a stepwise manner, as you've seen here, so that complicated cases are referred to a higher level. And at the lower level, they deal with really minor cases. So out of the 6 levels, the 5 levels are usually controlled by the county government. So, and the 6th level is now controlled and fully funded by the national government. So in the first level, which is now the community, this is just a simple like this can be your family doctor, to your nurse, to your school nurse. So this is the first care or first step you take when you're accessing health in Kenya. So this is at the community level, and they treat minor ailments, from like HIV testing to treating simple conditions like diarrhea, having a malaria rapid test, etc. So they do the really simple stuff. However, in the second level, which we've got now, different combination of the dispensary and the health system and the health center. So at the health dispensaries now, they've kind of expanded from the community level. They have an outpatient service, TB services, they've got even labs so they can do some tests, they've got pharmacies, and even antenatal and postnatal care. So, and they also start now issuing referrals. So if they're unable, because since they're limited to outpatient, they can further refer you to a level higher. So in the third level, which still comes under the second tier, is the health centers, which are also known as small hospitals. They actually provide very minimal facilities, so they are very similar to the dispensaries. The only thing is now they provide inpatient services, mostly focused on maternity. And they also now begin to have like constant focus on the non-communicable diseases. So they have diabetes clinic, hypertension clinic, a baby wellness clinic, a TB clinic, and and at least there has to be one doctor to run the whole health the health center. That's one of the requirements. And a dispensary can be run by a fully registered nurse and qualified nurse, of course. Now, coming back to the third tier, or basically the new third level, there's the fourth level. So now the whole point of the third tier is to now provide a holistic service. And usually it's a doctor or a medic that usually runs the whole hospital, which is now at the third level, and which includes now the level 4, which is the district hospital. So what happens in the district hospital is they now provide a bit of advanced. Now you see in level 3, they were limited to the labs, pharmacy, and inpatient. Now in level 4, they will go to now having x-rays and more diagnostic equipment. And if you climb up the ladder to level 5, they will be having now ultrasound, CT scan, surgeries introduced at level 4. So a patient who requires surgery will not be able to receive surgery at the first 3 levels. They'll begin to receive surgeries more at level 4 and level 5 at the provincial level as well. So this is just, and even the bed capacity increases, the number of the patients they can admit also increases. So that's how it's all about, it expands as you go up. And also research can be conducted, any health research can be conducted from a level 5 or level 6 or the tier 4 level, which is now the new system that is being put in place after the devolution. And now at level 6 is usually the national referral hospitals. So we've got 6 national referral hospitals, which are the major hospitals and are fully funded by the government and not the counties. The level 5 hospitals are more of county referral hospitals because they are the major referral hospitals for counties. So I'm using the term referral here. It's because if a patient is unable to receive treatment, let's say at level 2, they are going to be referred to a higher level, and that's how the referral system works. This may be sometimes difficult because, okay, the reason why we have such a whole pyramid system is because not all facilities or not all counties are able to provide really high technology services, and there are not even enough healthcare specialists like neurosurgeons and orthopedics. And I'm going to give you a really good example in a story of a patient. So for example, if a patient is presenting with headache, severe headache, blurry vision for quite some time, for let's say over a month, and he's also having like weight loss, and he comes to the community level, at the community level, they won't really help him much because he will require some labs. So the community level will refer him to the dispensary or the health center. So at the health center, he will basically get some lab tests. He will probably, because it's mostly outpatient, he won't be admitted, and they can't make accurate diagnosis. So they'll probably make some differentials, and he will be referred to a district or a provincial hospital. At now the district hospital or provincial hospital, he can undergo further tests like a CT scan, and even if it's like, if he has increased intracranial pressure, they can now perform interventions to reduce the increased intracranial pressure, and he can get even further diagnosis. And maybe the CT scan shows that he has a brain tumor. Now at the level 5 hospital, they have surgical equipment, but they're not able to perform any form of neurosurgery because they don't have neurosurgeons. So that patient will have to be referred to a level 6 hospital where we will have neurosurgeons available. There'll be equipment to carry out neurosurgery. So in short, like the more complex the case of a patient, the more steps he has to, the more difficult it is for him to access a really good and quality healthcare. So that's how the whole system is designed. And the reason why it's designed, because at community or dispensary level, you cannot have, there are not enough medical specialists around in the country as well, and there are not even enough equipment in order to carry out diagnostic levels at community level. Yeah, so just to look like, for example, this is Kenya's major referral hospital. This is where I go to university, Kenyatta National Hospital. So it's the major referral hospital for the whole of Kenya and the whole of Eastern Africa. So when you go there, you see patients from Rwanda, from Tanzania, from Uganda, because it's basically, it sits in the center of East Africa, and it has one of the top specialists within the region, East African region. So it's like the major referral hospital. So really complicated cases do come here if they are unable to be solved within the other lower levels. Also, like this one is NTRH, Moi Referral in Eldoret. This is also another national referral hospital. Like this will be a level 5. And yeah, so this is just basically some pictures to give you an idea of how the hospitals look in real. Yeah, so the Ministry of Health, now that we've understood that the different counties have control over the health, so what is the role of the Minister of Health? So the role of the Minister of Health serves as an umbrella body over the whole health system in Kenya. So they basically just plan, coordinate policy development if it comes to any health-related policy that requires policy implementation, health information systems. They're supposed to collect data and keep up to date with any emerging diseases. For example, right now in COVID situation, the NIH is taking the lead in ensuring that the countries are fully equipped with in case if it's budget allocation or ensuring that that Kenyans are healthy, passing out guidelines. And so that's basically the role of the Minister of Health in Kenya. So they serve as the umbrella body. So it's just like our NMO, Msake, serves as the umbrella body for all the medical schools in Kenya. So that's what the MOH does, something very similar. The National Hospital Insurance Fund, I also saw that Sudan, I learned, also has the NHIF. So basically, the NHIF is the national insurance that is available from the government to the public. So it's only available to Kenyans over 18 years old. And its main goal is to provide accessible, sustainable, and quality health insurance for all Kenyans who have attained the age of 18 and have a monthly income of around 1,000 shillings, which translates to around $10 and above. So the NHIF basically provides the insurance cover for all Kenyans. All Kenyans have a right above 18, and what that does is that they're able to pay for their outpatient services, their inpatient services. So the benefit package is quite good because it allows people it improves their accessibility to healthcare. So they are more prone to now visit a doctor, and because they don't need to worry about having to pay lots of money. However, maybe the problem with the NHIF is that the patient would be limited to only visiting public facilities because that's where the healthcare would be more affordable and the insurance is able to even further cover it. So from my experience with NHIF, some patients are not even aware that NHIF is there, but over time this is improving. There's more awareness and people are actually enrolling into this insurance program so that they're able to cover healthcare for themselves and their family as well. So even it covers for the dependents, and it's only available to, of course, Kenyan citizens. And so far, like over 25 million Kenyans have an NHIF cover, which is really good. The reason why I'm talking about maternal and child health care is because if you look at the population dynamics of Kenya basically has a broad base in the pyramid. So the pyramid is here, where really it's a broad-based pyramid, unlike Western countries where the pyramid actually is narrow. So in this pyramid, like very few people attain the age of 60, like very few people live above the age of 60, and very many people are in the base of the pyramid. So that means we are a very youthful, very young population. We have so many children, and that's why one of the indicators that actually really tests the strength of our healthcare system or really challenges our healthcare system is both maternal and child healthcare. So that's why it's very important for all county governments or even the national government to constantly check on the numbers and the figures and ensure that our women and our children are safe and the mortality is reducing, because we've got a very high population, a very high birth rate, a really high daily birth rate. So, and of course, limited services. So it is one of our government's mandates to ensure that the maternal and child health is safe. And that's why it's very crucial to our government. So you can see maternal mortality is around 362 maternal deaths for every 100,000 live births. If you were to take this figure back 10 years ago in 2010, this would be like around 500. So basically the curve is declining, which is a good sign. And even under 5 mortality rate is also decreasing. So it's currently, so in short, around 41 children actually die for every 1,000 live births. So this is one of the two major data that really challenges our healthcare system, and that's why the health care system really focuses on improving maternity care and even improving pediatric care. Top causes of death in Kenya or mortality: HIV/AIDS, lower respiratory tract infections, diarrheal disease, especially very common among children, neonatal disorders, tuberculosis, road traffic accidents, another emerging problem, and even non-communicable diseases, which is mainly a Western issue that is now also evolving slowly here in Kenya. So this is mainly, this is what usually challenges the healthcare system on a daily basis, and we always, as part of the healthcare system's mandate, or is to basically reduce mortality and morbidity from people suffering from all of these conditions. Yeah, so a bit about the private health sector. So the private health sector isn't, they have their own policies, they very different from the government, and their main role is just to fill in the gaps for that the public health sector has left in. So there's usually private for profit, so they're hospitals who are just there for profit. And they're very expensive. There's private not-for-profit, so these include the NGOs, and they're faith-based institutions as well that operate at a private level. So the private in Kenya is quite expensive, and also the NHIF doesn't really cover much of the private sector. It's because of the rates are quite high. So if you want to be able to afford private healthcare, which is of course very good quality healthcare because it's only meant for the wealthy, you can take a private health insurance, or or you just have to pay out of your pocket. So this is just the private health sector in summary. Yeah, so this is a comparison between how many Kenyans actually visit government over private, and you can see nationally this is quite recent data. So nationally, like majority of Kenyans would visit government hospitals. This is because the private hospitals are used by much wealthier, the wealthy in society, which are very few here in Kenya. There are not very many as well. And of course, if you're to look at the childbirths, this is a good sign because majority of women are now giving birth in a health center as compared to their homes. So this is a good thing, because before a lot of women were giving birth at home, and it would lead to complications such as hemorrhage, and they would high maternal mortality as well. So these are some of the improvements in our healthcare system that we're seeing, and women, and this is because the reason why we're seeing an increase in number of childbirths now within a healthcare center is because now it's free. For every expectant mother, she can deliver her child for free in any government hospital. So or public in the public hospitals. So that's the reason that's one really good thing our government did, and we are seeing less, and that's why maternal mortality is reducing. Because when you're in a hospital and there are any complications, the doctor is able to identify and carry out the correct interventions. Yeah, and nationally, so just as a general statistics on where Kenyans seek treatment, and as you can see, majority of Kenyans seek treatment from traditional healer or a herbalist, and maybe very few seek treatment from Kenya. And you ask yourself, why is this? Why are people not going to doctors? This is because we have very few doctors in the country. We have approximately around 15 doctors for every 100,000 citizens in the country. So that's quite low. We've got very few healthcare specialists. So you'll end up seeing that majority of people will seek health from the traditional healer. Also, there are probably there's many disadvantages of seeking healthcare from a traditional healer, because most of we've seen also, I've personally seen very many complications from the medications that the traditional healer gives them, and it's because there are not enough even healthcare facilities. There's no awareness on the importance of Western medicine, and the importance of practicing evidence-based medicine. So this is one of the challenges that our health system is facing at the moment. And we really hope, even with Corona, we're seeing an increase in, people not believing that it exists, and there are lots of myths like, having lemon juice will help you, will kill the virus, and so many things. So, this is one of the major challenges that we face here in Kenya, or the health system faces. Yeah, so that is it about our healthcare system. There was a lot, but that's just it in a snapshot. So now I'm going to talk about medical education in Kenya. Yay! So this is medical school and how it works. Yeah. Okay. So medical school in Kenya. So in total, we have 9 medical schools, and all of these medical schools are under our umbrella body of MSAKE. We have over 5,000 medical students. 6 of the medical schools are public, while 3 are private. And so the degree that is usually earned is Bachelor's of Medicine and Bachelor's of Surgery, which is known as MBCHB. That's the degree that you attain. And duration, it takes 6 years to attain that, the degree of MBCHB. And this does not include the internship. This is just purely the undergraduate program. So if you're to go and in a public university like the one I study in, so in a public university, there are 2 types of students available. So there's the government-sponsored student, and there's the parallel or self-sponsored student. So they're called parallel or self-sponsored, which they have to pay out of their pocket. But the government students are usually the very bright students that graduate from high school, and they get government scholarship to study medicine in any of the public universities in Kenya. So this is my dear friend Sharon. That's her picture. So medical school entry requirements. So this is one of the this is one of our high school certificates. It's known as KCSE, Kenya Certificate of Secondary Education. So the highest grade attainable is an A, of which you're qualified to receive a government sponsorship after if you make an application, and it's very competitive, and there are very few spots available. So you get a government sponsorship or scholarship where they actually pay your fees or cover majority of your medical education fees. And this is not on a loan basis, this is a pure scholarship, and you're able to continue your medical education within the 6 years. And then if you attain a grade, again, between A to B+, then you're eligible to enter medical school, and this is self-sponsored. Now you'll have to pay out of your pocket. And they're private. You can actually take a loan, but this is not government-based. These are usually some not-for-profit organizations or bank loans in order to pay, or your own personal pocket. You can pay out from your own personal pocket. We also have the international curriculum. So we've got the advanced levels, which is the British curricula. So also medical schools can take that. Students who have done the advanced levels, which is done in the UK. Of course, the grades ranging from A to B, and there's the IB, which is more the American curriculum, but very few students, like they probably one student a year is admitted, because there are very few students who actually do IB. So again, medical school is largely divided into the preclinical years and the clinical years. So that's the undergraduate program. So preclinical years can range from 1 to 3. So like in my university, the preclinical years is the first year and the second year, and then from third year it goes to clinical. But in other universities, the clinical starts from 4th year and above. So that's why the 3 is in between. So it just varies from university to university. So the preclinicals, of course, you learn the basic sciences such as human anatomy, where students are given a cadaver to dissect for a whole year. So you basically spend a lot of time in the anatomy lab and carry out dissections and learn about the human body. There's also physiology and biochemistry. These are just the core subjects. There are also other units, but these are ones that are shared across all 9 medical schools. We've also got the clinicals. Now, this is after your 3rd year, or during your 3rd year, or after your 2nd year, depends on the school. You learn now other units like microbiology, pathology, pharmacology, psychiatry, community health, where you actually go into the community, carry out some research work, or learn more about health or primary healthcare within the community. And there are also other units that are taught. I just haven't mentioned them because they vary from different universities, but they include medical law, and so many other units as well. So clinical rotations. So these are the compulsory rotations that are usually done, and the major ones for more than a year. So that's internal medicine, surgery, pediatrics, and obs and gyn, OBGYN, or yeah. So however, there's also the other micro rotations such as orthopedics, cardiovascular, even what else? Ophthalmology. So many other minor clinical rotations are also available. There's also psychiatry as well. So where you go to a psychiatric hospital and you learn more about psychiatry there. So these are all clinical rotations, and this is basically the major subjects that we learn in university throughout the 6 years. Assessment. So how are we assessed? So we have continuous assessment tests, end of semester, and even end of year examinations. Our clinical examinations, we've got the short case. So in the short case, you'll be taken to maybe a patient or a pediatric patient, and you're going to be asked what's the diagnosis. This is without taking a history or an exam. So this is basically on first impression. And the long case is where you're given an hour with a patient and you discuss, take a proper clinical history, understand what the patient is going through, and come up with now differentials, of course, and come up with a plan and management on how this patient will be managed. And you present your case to a senior lecturer or a consultant. And then you've got even the OSCEs. The OSCEs as well, something that is we do also in our exams. So it's just basically you're given, for example, you're taken to the patient's bed, and on the bedside there's some questions written that you're supposed to do, or you're supposed to answer, or you're supposed to ask the patient in order to figure out the diagnosis or something like that. So OSCEs are there. Practicals, you've got a spot exam. This is common, like for example, in human anatomy or microbiology, where you're given a specimen, or even pathology, you're given a specimen and you're supposed to identify or describe or mention the diagnosis. And then also some practicals require just making reports and just submitting them as well. So this is how we are assessed in medical school. This is something extra. So there's something called an intercalated bachelor's course. So this is only offered though in one LC, local committee, or one university, the university I go to, University of Nairobi, where students are given an opportunity to do a bachelor's course in anatomy or bachelor's course in physiology. So this is not compulsory. This is like in other countries they call it like a year where they do the thesis. So it's something very similar. So it's basically a research intense based course. So it's just mainly focused where you just go 1 year and do a research in anatomy or do really research in physiology. And this is usually done after your second year in medical school or your third year in medical school. And at the end of the day, you earn a degree of either first class honors or just honors itself. So it's just research intense. It's not compulsory, but it's for really motivated students who are really interested in research and planning to come back to the university and become lecturers, or really interested in anatomy or physiology. So it's 1 year, and students take that gap year in order to complete this course. Electives is also part of our universities. It's for some universities it's compulsory. For others, it's highly recommended that you have an elective term. So this is usually conducted between your 4th and 5th year. For some universities, it's in between their 4th years, just ranges, but usually between 4th and 5th, or 5th and your 6th year. So the university exchanges, this is where the university actually sponsors a student to go to another country and do an exchange with which the university has a contract with. So that's during the electives, and also exchange students come in. So this is just university-based exchanges. Then we've got the IFMSA exchanges. We've got the Scopi and the Scori exchanges available. Yay! And we've also got local electives where students can go to local hospitals and in the different counties. There are also research electives. Students can take the elective term and just do research in the country, or even their surgical electives as well. So this is just basically the extras or the bonus stuff that you can do in med school. Yeah, so what happens after your 6 years? So after your 6 years, you graduate, you become a medical doctor, and then you do your internships. So you become a doctor, but then you do a 12-month internship. So basically, if you went to a public university, you can choose. You have an option to either go into a public hospital and do internship, or go into a private hospital and do internship. So what happens is that after your 6th year, the university does a balloting where they randomly place you in any of the hospitals in the different counties around the country. So that's what happens. So it's never your choice. You're never given a choice on where you'd want to do your internship. That's if you want to go and intern with the government. Unless you do private, that's your choice. But otherwise, if you want to intern, which is preferable, it's always good to. Majority of students always end up doing internship with the government because of the really high level of experience and the high pay, of course, from the government. So, but you don't have a choice on where to go and intern. And of course, during the 12 months internship, you get to rotate in various wards, and after 12 months, you become a medical officer. And you can continue doing you can continue just being a medical doctor, a general physician, or you can now apply for a postgraduate program. And the postgraduate program, depending on the program, it can range from 2 to 6 years. So like neurosurgery would take 6 years in Kenya to if you want to become a neurosurgeon. So this is basically how things work here. And yes, this is just a glimpse of medical students. You can see here where my point is, that's our president of our NMO, Nicholas. This was us during our SRT. This was the Scora Outreach. Students from Ozima University. So this is just a glimpse of medical students, how we do. And we also have fun and have our good times. Yes, asante. This is the third Kiswahili word you're going to learn. So we learned jambo, we learned karibu, which means welcome. Jambo means hi, karibu means welcome. Asante means thank you. So thank you very much for giving me the opportunity to talk about the country I love and the country that is very close to me. Please feel free to contact me if you have any questions or you'd like to learn more about Kenya. Or if you ever visit Kenya, you can always, feel free to know where to go. Thank you very much. Yeah, thank you.
Thank you, Esa, for this amazing presentation. You're really nice. Thank you. We love it. And next, we have Bismarck from Ghana. I will share your presentation.
Hi guys.
Just a second.
I just want to do a little bit of like a mic check. Can you hear me? Monique, can you hear me?
Yes, we can. Yes.
Yeah, it's because it's been storming a lot here lately, so the reception is kind of bad. But if you can hear me, that's good, right?
Yeah, it's perfect. I'm just waiting for the presentation to start showing up.
If we stop hearing you, we let you know. But so far it's perfect, okay?
Even before like the presentation comes on, I would just want to talk a little bit about Ghana. So hi guys, once again, my name is Bismarck, and then I'm from Ghana. Ghana, it's just like a very nice country in the west part of Africa. We have a lot of beaches, a lot of castles from the slave trade era, and then we also have a lot of green forest and a lot of places to chill and relax. And so once I'm just going to give a little brief intro about Ghana's health system and medical education, you should probably be thinking of spending a summer in Ghana. Yeah, I mean, not this summer because of COVID, right? So probably the next summer or anytime you have free. Okay, so I will be waiting for the presentation.
I think it's coming because for me it's already showing. But
yes, it shows now. I can see it now. Okay, so let's just like dive straight into it. We're just going to talk a little bit about the health system of Ghana and then the medical education in Ghana. And as I give you a little bit of overview, Ghana is in the west part of Africa. And then it is not such a big country. We have about 30 million population, which is like a lot, but like Ghana is not a big country. But we have like a wonderful system of health, if I should say it that way. And then we also have a very wonderful medical education system. So I'm just going to go straight to the point. In Ghana, most or the majority of health is only under the Ministry of Health in Ghana. So the Ministry of Health is the one who is in charge of everything health in Ghana. So under the Ministry of Health, we have different agencies that offer health services. And I just put some list of some few ones because there are a lot of them. The first one is the Ghana Health Service. Don't confuse that with the ministry. The ministry is like the whole bigger umbrella, and under that we have the Ghana Health Service. We also have the Christian Health Association of Ghana. We have a lot of churches who have hospitals and then pharmacies and then a lot of like health outlets. We also have the National Health Insurance Authority, which is a body under the Ministry of Health. We also have private hospitals and maternity homes, everything private, as Yusuf said. And then we also have a lot of other health associations like the Medical and Dental Council, the Nursing Council, the Midwifery Council. We have different like bodies under the Ministry of Health, but these are the most important ones that I want to share with you. And I actually put the Ghana Health Service in blue because about like 95% of health services in Ghana is provided by the Ghana Health Service. We go to the. Can we go to the next slide, please?
Sorry.
Yeah. So the next slide is just a little bit overview about how the healthcare system in Ghana is arranged. We have 5 levels. I can see that Yase mentioned in Kenya that they have 6 levels, but we have 5 levels of healthcare service. The first level is called the health post. These are like small centers in places such as rural areas, like very small rural areas in the country. After the health post, we have clinics. It is actually in order of like increasing ascendancy of, let's say, how big the hospital and the more service that they offer. We have clinics as the second step, and then we have district hospitals, and then we have like regional hospitals, and then we have the tertiary hospitals. So the issue is that based on where you are, you can enter the health system from any of these posts. But usually everybody enters the healthcare system from like the health post or the clinics. So for example, I will give an example. If you live in a very rural area, there's definitely not a district hospital there, but you would have a health post or maybe a clinic. So that is where you receive your primary healthcare service. But for example, if you live in a town or a big town, or let's say in a city, you would also have to enter a district hospital for your primary healthcare services. But the good point is that you can also enter a regional hospital for your primary healthcare services because the bigger hospitals have also smaller places in the hospital where they provide uncomplicated services. I mean, if you need just like, if you have malaria or something small like a headache, even if you go to the regional hospitals, there is also like a place in the regional hospital where you can get service, not necessarily going to like the sophisticated part of like the regional hospitals. So basically, we advocate that everybody enters the healthcare system from a primary healthcare point of view, such as like the health post or the clinic, so that we prevent a lot of congestion in the regional hospitals and tertiary hospitals. However, you can like enter from any of these places and still get like primary or like minimum healthcare services. Okay. Can you move to the next slide for me, please?
Yes.
Yes. So I would want to talk about the general policy of health in Ghana. In Ghana, the general policy or the principle we have is universal health coverage, which started somewhere around the 2004s. We realized that not a lot of people could get access to healthcare. So the government decided to find a policy that would make sure almost everybody gets access or like everybody gets access to healthcare. So that is the major principle that we have in the country. I mean, there are challenges still, but like we achieve this universal healthcare coverage through 2 main ways. We have the first one as the National Health Insurance Scheme, and then the second one is called CHIPS. Well, it's not chips that we eat every day. It's funny but that we all call it chips sometimes, but chips mean community-based health planning and services. It is a form of a primary healthcare strategy that Ghana adopted to make sure that everybody, no matter where you are in the country, receives like health coverage. So these two main ways are the strategies to achieve universal healthcare coverage. So can we go to the next slide, please? Yeah. So I'll first talk about like the National Health Insurance Scheme. Okay, so the National Health Insurance Scheme, it's a strategy adopted by the government in the early 2000s to make sure that finances doesn't deter people from seeking healthcare, at least some quality healthcare or some primary healthcare. So the government started this to make sure that no matter who you are, if you can afford or you cannot afford healthcare service, you should be able to go to the hospital. Before this system was started, we were using the system called pay as you go service, or like pay and get treatment service. So you go to the hospital and then you need to pay a premium for your healthcare needs right at the time that you're going to the hospital before services are given. And then the system was really bad because there are a lot of people who cannot pay for like some of the basic healthcare that they need, which are really basic things that would save someone. So the government decided that they were going to stop that service and then bring in a very good service, which is like the National Health Insurance Scheme, which is going to cover almost everybody in the country to make sure that everybody gets a good health system. So the idea was to find a way to fund this scheme. So on the left side, you can see I put like the major funding schemes or the funding approaches for the National Health Scheme. First one is a National Health Insurance Levy, which is a 2.5% tax on some specific goods and services. And so this amount of money is put into the coffers for the National Health Insurance. There's also 5% of Social Security from like workers that also go into the National Health Insurance Scheme. And the third one, which is really important, is a premium paid by informal subscribers. I'm going to explain that. So we have two major subscribers of the National Health Insurance Scheme. We have the first ones are called the informal subscribers, and then the second ones are called the exempt subscribers. So I would really want to explain the exempt subscribers first, and then anyone who doesn't fall under the exempt is the informal like subscriber. So for the exempt, these are people who do not pay any premium or who do not pay any money for like the National Health Insurance Scheme, but they still enjoy the services given by the National Health Insurance Scheme. So some of these people are anyone who is under 18 years of age, pregnant women, that is through antenatal during the pregnant care, and also postnatal services. Also, differently abled people do not pay any money or do not pay any premium. If you're also mentally challenged, you do not pay any premium. And also, if you're above 70, you do not pay any premium. There are also other like categories under the exempt, but they are very special categories which the Ministry of Health deem it fit. But apart from these people, any other person is called an informal subscriber, and then you pay a premium based on like your level of work, and then let's say your level of income. But the premiums are really small. You pay them for a year, and then they're not like a lot of money. There's just like not so much. It's something small for a whole year to enjoy the services given by the National Health Insurance Scheme. And so the National Health Insurance Scheme was rolled out to take care of about 95% of like the commonest health issues that we have in the country. And I listed some of these diseases or some of the services the National Health Insurance Scheme would cover. So down there, you can see some diseases such as malaria, diarrhea diseases, upper respiratory tract diseases covered as part. And also like some lower respiratory tract diseases as well, skin diseases, and some chronic diseases such as hypertension, diabetes, and asthma. These diseases would be covered by the National Health Insurance Scheme. I didn't put some of the things that are mostly not covered by National Health Insurance Scheme, but I would say some of them like cosmetic surgeries, uh, some like high-end surgeries, like let's say if you need like a neurosurgery or cardiac surgery, there's some major healthcare services which are not covered by the National Health Insurance Scheme. However, all the basic ones that are very common, which I've listed here, are covered by the National Health Insurance Scheme. Okay, yeah, that's it. Can you go to the next slide for me, please? Yeah, so once you subscribe to the National Health Insurance Scheme, you get a biometric card with your picture and then with some details of yourself, your name, your date of birth. And then once you go to every health post, whether it's like the first level, the district clinic, the tertiary level, or the regional level, and you show this card, you are able to access the health services over there. So this is a card that a lot of Ghanaians have. I didn't put in some extra information, but I'll say it's that we also have like other private health insurance schemes. Most of these are by, let's say, companies who would want to have like a private insurance for their workers. Or maybe some people also have like private insurances from different posts. But I would say about like 90% of the country, everybody has like this government national health insurance levy, which is really good. And then it makes sure that everybody has access to good healthcare services, mostly the primary ones. Can I get to the next slide, please? Strategy to achieve universal health coverage is what we call the CHIPS, which I said is community-based health services and planning. I would want to explain it because it's not a difficult concept, but it's kind of like special for Ghana. Usually what we do is that we realize that it is really difficult to get like health services to the very local or the very remote part of Ghana. So in as much as we wanted to get primary healthcare services to these places, we devised a strategy called the CHIPS. And then it is a system that the government tries to empower like the communities, these rural communities, to take charge of like uh, mobilizing resources, planning, and also delivery of healthcare services to make sure that they join in the quest to get good primary healthcare services. So it's a whole intersectorial relationship between households, the community, and the government. I'll give you an example. Let's say I'm like a small community somewhere in the remote part of Ghana, and I realize that I need healthcare. What we do is that these people in the community come together, and then they can bring out what they can help to make sure they have like a very good primary healthcare system. There are instances where the community people have started like or raised a small building called a CHIPS compound. And then this compound, the government would provide a health personnel who would take care of like the primary healthcare needs of the community. So what they do usually is that every help that they can get, sometimes they even provide the personnel who is in the community with food and accommodation. So it's a very good system where the community, together with the government and other stakeholders, decide to make sure that they have a solid system of primary healthcare in their community. And so this rather would become like the first primary healthcare service for such a community. And then that CHIPS compound or that CHIPS location will be linked to a clinic and then to a district hospital and then to a regional hospital. So if you come to the country, almost all the rural areas have this CHIPS system where they make sure that they bring out anything that they can use to help. One of the things that really helps with this chip system is that it's also the main post of medical education to the rural areas by the government. So the CHIPS personnel are always trained at the district level, and then they move into the rural places where they give medical education and also give other services such as like antenatal services, and then very important simple services that are not available to such rural places. Because most of the problem is that some of the rural places do not have, let's say, good access to good road, and then access to proper healthcare. So if they don't get like primary interventions before they are brought to the clinic level or the district level, it will be catastrophic. So the chips help us to make sure to give primary healthcare services to the remotest part of Ghana. Recently, the government also decided to help the CHIPS approach because there was a lot of maternal mortality death or the maternal death because of blood loss and also some minor issues with drugs that were not available. So the government signed a contract with this drone company, and so the government can ship emergency services such as blood and then drugs to CHIPS compounds and to clinic level and district level, right from the tertiary level, right from like the capital or the major Ministry of Health. So the CHIPS level will just have to lodge in a complaint, and then in some few minutes they can have a drone full of like medical staff. And this chip system, once it was introduced, has really bridged the gap between healthcare in the local system, in the local communities, and then the people living in the cities. Okay, so this is basically what the government of Ghana has with respect to like health systems. But there are a lot of challenges that I would want. Most of the challenges are like logistics. Well, there are some communities who have raised up CHIPS compounds, but like they do not have like adequate personnel to provide the services. And then also there are doctors and then a lot of health personnel. Also, there are not a lot of other logistics such as maybe drugs and other issues with respect to the healthcare system. So these are simple challenges that we are facing, but every year the government tries to improve the primary healthcare system, because once this is able to be perfect, like we can have everybody receiving very good healthcare system. Okay, can we go to the next slide, please? Yes. So that was just like a little bit of information about the Ghana Health Service. And so now I will talk briefly about the medical education in Ghana. Yeah, next slide, please. So the Ghana education system with respect to medicine is very simple, and it's also very similar to what Kenya has. So usually our high school is 3 years. So you do 3 years of high school, and at the end you write we have a West African exam for high school. So our exam, it's just basically the same exam written by Nigeria, by Sierra Leone. So all the West African English speaking countries, we have the same exam for like finishing high school. So it's a really major exam. And so right after the exam, you qualify to enter straight into medical school. So you don't have to do a degree, or like you don't have to do some pre-med before you enter medical school. Right after the 3 years, in the same year, you can enter medical school. But entering medical school is like so difficult because there are a lot of students who want to enter medical school. There's so many people who want to be doctors. So usually we have about 7 medical schools in Ghana. We have 5 government or like public ones, and then we have 2 private ones. Usually, every school has their entrance medical exam and then an interview. So once you're done with school, you're done with high school, you decide which medical school you want to go. We don't have like a central application system, but I think we are working on that soon, which will be probably rolled out next year. So you have to apply individually to the medical schools that you want to go to, and then you buy, or let's say you pay for an application fee for all these universities. But every university has an entrance exam and then an interview. Every year we have, if I would just like give an estimate, every university would have almost close to 1,000 students sitting for this entrance exam and then interview. But you have approximately every university, the major universities will approximately take about 200 students per year into medical school, and then the private ones a bit lesser, so maybe about 100. Yeah, but it is really hard to get into the medical school. So you need to demonstrate a lot of intellect and then a lot of like skill at your interview. And then we have 2 entries, just like Kenya. We have those who are sponsored by the government, and then we have those who self-fund their own education. If you're sponsored by the government pays for your medical curriculum fees, and then you only pay something small, which is not even about like the fees. It's just like some few one or two things that you pay for, which is not a lot. And then, as Yese said, also for Kenya, this is not a loan. This is like a scholarship or a grant. You get this, and then you are sure that you are being paid for the whole of the 6 years of medical school that you're going to spend. But if you don't get that, everybody can actually apply for this. But the thing is that they choose the best of grades students and the best students who come out of the interview. So it's also really top notch. And then it depends on how well you do. And then mostly we have about half of the total students being government sponsored. And then we have about another half of the left being self-funded. And then we also have a lot of international students in Ghana. So in Ghana, we have a lot of students coming from all over Africa, mostly West Africa. We have a lot of Nigerians, Gambians, Sierra Leoneans. And then sometimes we have people coming from like even Europe and Asia. I was in a class with like a Japanese friend. And then we have different entry points. They're able to grade your high school points into our system so that you can also enter the medical school. Yeah. So in the medical school, all the medical schools in Ghana are for 6 years. 6 years. It's just like a central system. There was one which was 7 years, but recently reverted to 6 years so that all of us have like 6 years of medical education. These 6 years are divided into the preclinical and then the clinical years. There's just a bit of difference here because for one particular medical school, these preclinical years leads to an award. I think two of them, it leads to an award of a certificate. So the first 3 years we have in my school something we call a bachelor's of human biology. So after the 3 years, you actually do a graduation, just like maybe you would say a white coat ceremony, but it is actually a graduation where you get to graduate with a certification of BSc of human biology. My university does this because I think there are some people who go into medical school and maybe halfway they realize that, oh, maybe I cannot continue to be a doctor. Maybe I have a passion in something else. So after 3 years, you have a degree and then you can pursue other things. You can decide not to do the clinical years and then pursue other things. But about 3 medical schools in Ghana would not give you a certificate, and then you would have to finish the other 3 years before you get your bachelor's in medicine and bachelor's in surgery. So the first 3 years, you would do the basic preclinical courses, anatomy, physiology, biochemistry, some pathology, and then you do some chemistry and some math. Yeah. And then in the clinical years, this is following like the preclinical years, right after like the preclinical years, you move into the clinical years. And then in our clinical years, you have to be resident at a tertiary hospital. So every medical school is linked to a tertiary hospital. So you will be a resident, and most of us have hostel facilities right in the hospital, which is like just a minute walk into the main hospital. So you are supposed to stay in the hospital, and then there you do all the things we know: rotations in internal medicine, in surgery, do rotations in the subspecialties of ophthalmology, cardiology, everything that you do in medical school in the clinical years. And then this is how like medical school is. Right after the 6 years, you write your final exam. Your final exam, your licensing exam is your last exam. So you don't sit for like a special licensing exam after you're done, just like in other countries. Your final exam, which is usually in internal medicine and then surgery and then community health / public health, is your final exam, which is also your licensing exam. So after this, you are a doctor. After the 6 years of medical school and your final exam, you are a doctor. But then our system continues. Once you're a doctor, you move into what we call 2 years of housemanship. Well, people would call this an internship, but like we call it housemanship, really following the UK system, because you are a doctor, just that like you still learn a bit under supervision. And then the 2 years of housemanship, the first year has to be done in a tertiary hospital. it is compulsory to do the first year in a tertiary hospital, because you will still need to learn a lot of things that you haven't learned in medical school. And then you get these things more in a tertiary hospital. So these 2 years, you do 6 months of 4 different rotations, 6 months of surgery, and all the subspecialties under surgery, 6 months of internal medicine, pediatrics, and then 6 months of OBGYN. We do this a lot because, as I said earlier, we don't have a lot of doctors, and then we also need a lot of general practitioners to be working in different parts of the country. So what we do is that we make sure that every doctor coming out can do almost everything, so that you can be a general doctor to manage anything, the basics of any specialty that comes your way. So in the first year, you do 2 of these rotations in a tertiary hospital. And then in the second year, you have to move to a regional hospital. That's your second year of housemanship, but you're still like a doctor. So you move to a regional hospital where you do the other 2 rotations you didn't do in the tertiary hospital. Now, after these 2 years of housemanship, you are supposed to do 1 year at a district hospital. Now, what you do at a district hospital is now you give, like, you have a lot of scale in almost all these 4 parts of medicine. And so in a district hospital, you can manage basically all cases around this, and then refer extra cases that need extra attention to the tertiary hospitals. So that is what you do after your 2 years of housemanship, and then you do 1 year of a district rotation. Then after that, you can enter into your residency program. These 3 years are like mandatory for everyone to do, but well, somehow some people can do the 2 years of housemanship and enter straight into residency. But the real rule here is that you have to do the extra 1 year at a district hospital, because that is how you can also learn so many stuff, so many emergencies on your own, so many ways of managing like different cases on your own. And then I think somewhere last year or this early part of this year, the government made residency in Ghana free as well. So anyone who enters residency in Ghana has free tuition now. And then you enter the residency and you choose what you want. But there's also an entrance exam to residency. So you write the entrance exam to the particular residency you want to do. And then you have like the member in that residency and then the fellowship in that residency. You can do this anywhere in the world, or in Ghana, we have the Ghana College of Physicians and Surgeons, which is one school that offers the residency. And then we also have the West African School of College of Physicians and Surgeons that also offers residency. You can choose to do a West African brand. If you do a West African brand, you can practice in all the West African countries, or you can also do the Ghanaian one where you can mostly practice in Ghana. Or you can also decide to go outside the country anywhere and then do whatever residency you want to do. I would just want to add that usually when you are done with the 6 years of medical school, mostly if you're a government sponsored person, you need to do the 2 years of housemanship before you can go outside any country to do a residency. Yeah. Can we go to the last slide, please? Yeah, so this is just some few information about like the medical education. I knew the question would be how hard is it to get into medical school? It is really hard. It's let me say less than 20% of students, 20% is probably more of students who want to get into medical school actually get into medical school. And then you can try so many years. Personally, I tried 2 different years before I got in. Yeah. And then, as I said, there are 5 public medical schools and then 2 private ones. And usually we have a lot more females in the medical schools than males. And then also another information that I put there is that we have the government sponsored ones and then the self-funded ones. So this is basically a little bit overview of the medical education in Ghana. I would just say that just come to Ghana. If you still want to do medicine, you can do it in Ghana because we have a very good medical education system. And then even as students, you get to do a lot of practice in the tertiary hospitals because like the patients are really free, and then they don't mind students like I wouldn't use the word experimenting, but they don't mind students learning from them. And so we have a very good exchange system because of this, because students from different countries are able to learn a lot of things about tropical medicine, because it is a very friendly medical education system. And then the only thing I would say is that there's not a lot of vacations in the medical education system. It's so much intense that once you get into the clinical years, there's not so much of vacation time. But yeah, we make sure we give some particular months for electives so that students can take elective breaks and also take some breathers in the semester. Thank you very much, and I hope you enjoyed. And then I hope you have questions for me. I'm ready to answer.
Thank you very much, Bismarck. It was really nice to hear everything you said, and like you even answered some questions already in your last like slide. I think you're already ready for the questions because the first question we received was for everyone to answer. Like, if you know, like the proportion of males and female students in medical school. So you already answered it in your last slide.
Okay, so in Kenya, it's pretty much fairly balanced. We have equal number of males and females within the medical school. I'm not too sure of the exact statistics, but from what I know, it's really balanced because that's what they do take into considerations when admitting students into medical school.
Ibrahim, are you there to answer? Should we just read his answer? I don't know. Okay, he's there. I will just read for him the answer. So, the majority of medical education in Sudan are females, around 57% of females and 43% of males.
Next question is a question to everyone again, asking your opinion on which is the most challenging, what's the most difficulty that your country faces regarding the health system.
Okay, I'll go first. So in our healthcare system, I guess the most challenging is about in terms of accessibility to health, because as you saw the whole pyramid, a patient suffering or having a complex disease will have to take quite a long journey in order to reach a medical specialist or even to get a diagnosis or treatment, and even the whole process from the day the diagnosis is made to the day the patient leaves the hospital is it takes quite some time. So I guess that's the major challenges is accessibility to health.
Okay, I will go with mine. For us, accessibility, well, it's not the major problem because the system makes it easy for you to go. But one of the major challenges, I would say, too, the first one is sometimes people do not want to use the system. I think you mentioned something like people would rather want to do traditional medicine at some point in time. So many people come to the hospital when there's like uh, complications more than just like coming with basics. So like it becomes difficult, and at that point they would need interventions that the health insurance would not be able to cover. So then the last one is like not enough funds. I hope it makes sense.
Right. I wrote my answers below in the chat section, just in case you guys cannot hear me or anything.
So what Ibrahim sent us is that the biggest challenge in Sudan is proper management and financing by the Ministry of Health, and also balancing between the different rural states in Sudan. Next question goes to Yasser. First of all, congratulations for your presentation. Loved it. That was the comment. That's not me. Does Kenya have fellowship programs?
Thank you very much. Okay, fellowship programs, we do have some fellowship programs. Usually the fellowship programs that happen after you graduate, but they're very few. Most of the programs are usually focused in the public health area. So if you're really interested in doing public health or getting into public health research, they do offer fellowship programs. We also sometimes have fellowship programs for research for HIV vaccination, because we have one of the institutes that actually focus on trying to make one of the leading institutions in Africa in making HIV. So they are those fellowship programs. So yes, and you can always come to Kenya for an exchange or a fellowship. Yeah.
And next question is for Bismarck. When did the government start the NHIS?
Okay. Yes, the government started the NHIS around 2004. Particularly, the idea was started around 2000, but it came into full force around 2004. Yeah.
Okay, thank you. Next question is for everyone. Do people really respect the level of healthcare? In Brazil, the same hospital provides neurosurgery and also receive patients with simple sore throat. Not everyone respects the level of care.
Okay, I think I will go first. So this is also one of the problems we have. Even though we have like different levels, and then we wish that everybody enters from like the basic level or the primary level, some people have the notion that if they always go to the tertiary like the hospitals, that is where they're going to get the best of care. So like not a lot of a lot of people respect the levels. However, because
I believe his internet have some problem. So if someone else wants to go next.
I can go. If you guys can hear me now.
Yes. Yes.
Yeah. So generally, the different levels of healthcare systems in Sudan are. I don't want to say that they're completely respected, but generally people here know where to go. For example, if you're like head injury, you go to an emergency. You have a sore throat, you go to a primary health care center, for example. So it's generally not a big problem in Sudan. Perhaps the only problem is the huge difference between the private and the public healthcare sector. Where, for example, if you're a sick person and you don't have enough money to pay for the private healthcare sector, you might not be admitted as soon as possible, which might be a huge problem at the beginning. But generally, there is respect for the different the health levels. I mean.
So, okay, yes, as people actually do, I think, because this is because like some hospitals put some really strict restrictions that prevent taking like really small cases. Like, for example, our major referral hospital in the country, our national referral hospital, they mainly take referrals from other hospitals and they really avoid taking small ailments such as sore throats or diarrhea and stuff. And I guess people really know that. That if they want to go to the major referral hospital, they have to go if they have an appointment or a referral letter. And they also know that the amount of rush and the amount of waiting that is also available, so they wouldn't actually go into a really higher level of healthcare delivery system. They would actually go into a lower one. So people actually do kind of respect that the levels of healthcare. Thank you.
Welcome back, Bismarck. I don't know if you can hear me, but next question is for Bismarck. Is the housemanship paid?
Mhm.
Okay. Another question for
Yes,
everyone.
the housemanship is paid. Yeah, it's paid.
Sorry.
Hey, I'm done. I'm done. We can go on. Yeah, it's paid. Yeah.
I'm sorry to interrupt. So next question for everyone. How is the medicine student's relation with the health program?
Can you please rephrase the question? I think it's not very clear.
How is the medicine
Yes.
student's
I
relation?
actually don't understand.
Like, yeah, Juliana, what do you think? I don't know how to.
I think what they mean is like how do medicine students, how do medical students act, and how are they inserted in the health program, in the health system?
Well, maybe I'll try to answer it from one point of view. I don't really get the question well, but maybe the person is trying to see how do the medical students like the health like service or like the health program, or like how does the curriculum meets the health services.
Yeah, I think that's
I
it.
don't know
How
if
was the
that's what the
curriculum
person is trying to find
services? I think that's
out.
it.
But if that is it, then in Ghana we make sure that that's why you stay in the hospital. So like you make sure that you rotate every way like the hospital works. So your curriculum is planned such a way that it fits right into the hospital that you stays in it. So like I would say students like the health service in the country because it helps them learn. I don't know how the question is though.
The way I've understood the question is similar to Bismarck, is maybe what's the relationship between the medical students and basically the health program or the health system in general. So, okay, within our curriculum here in Kenya, we're actually given talk about the healthcare system, we talk about the medical laws that are available to protect healthcare workers and even patients. So we are actually taught that in medical school. Plus, we also interact with the healthcare system frequently because we rotate within the major referral hospitals here in Kenya. So that's how we also get to interact with how the whole process, or how the whole administration and logistics basically works within the healthcare system. We also have a program called Community Health, where we take a trip into the rural areas of Kenya and we do a community engagement program where we interact with the community, we understand the challenges to access healthcare, and we work closely with the government healthcare officials in order to who also further explain to us how the whole healthcare system works. So, yeah, medical students are partially involved, and actually, medical students are considered the non-essential part of the healthcare system as well. Yeah, thank you.
Okay, so the way in which I understood the question is how included are the medical students in the healthcare system according to the different medical levels and stuff. So basically, as I've mentioned in the previous part of the webinar, is that here the clinical practice in our universities begins since the third year of the university in most universities. So medical students are included in the healthcare system at a very early phase, and doctors rely on them for a lot of basic procedures such as cannulas, such as observing the patients, and a lot of things that medical students might not be able to do, but they're well trained to do it at a very early level. And they're usually very involved in the healthcare system in terms of the clinical rounds, in terms of the clinical lectures, in terms of helping out the doctors in the rounds themselves. Also, another example, when the pandemic hit Sudan like 2 or 3 months ago, yeah, about 3 months ago, um, the Federal Minister of Health asked a lot of medical students to come and volunteer and help in all of the hospitals that need more doctors and need more healthcare providers. So here, students are well involved in the healthcare system, and which is the reason why a lot of the people who graduate from universities here have a very good clinical sense because they're involved at an early stage, and they're usually given very basic and advanced procedures under supervision, of course. So they're very well connected to the healthcare system.
Okay, thank you. Uh, Next questions for everyone. What are the main areas of health system that receive more investments?
Maybe I'll go first. So here in Kenya, as I also mentioned in my presentation, a lot of investment is invested in maternity care, healthcare, and child under 5 healthcare. This is because, again, we are a very young, youthful population. Our birth rates are really high. And before a really long time ago, like just a few years ago, there was an increase in mortality rate, especially maternal mortality rate. That's because they couldn't afford to, access the hospital and and give birth or normal delivery, and they would suffer complications at home, such as dying from hemorrhage or not able to access a theater for C-section. So um, this is where the government spends money to ensure that all the women, expectant mothers, are able to deliver able to deliver safely in hospitals without having to worry about paying for their delivery or for the costs. So that's a lot of investment goes in protecting our women, our expectant mothers, and also under-child mortality because a lot of children also die from neonatal disorders, including also communicable diseases, which diarrhea is the major cause of under 5 mortality here in Kenya. So a lot of investment goes in protecting child healthcare, in vaccination. There's a lot of investment that goes in vaccination as well. So the main investment basically goes in areas that are causing high mortality. In fact, even HIV, there's a lot of investment in research in HIV. Like my university does a lot of research, including vaccination. And they're trying to develop a vaccine for HIV. Also, all those who are infected with HIV and AIDS receive counseling services. They get free medications as well, and free clinic visits. Yeah.
Okay, I would go next. I hope you can hear me, guys. Yeah.
Yes.
So exactly just like Isaiah, it's also because we have a broad-based pyramid system. So we have a lot of birth, and then we have a lot of issues with maternal mortality. So most of our investment also go to OBGYN and then pediatrics, making sure that we have the best of healthcare for mothers and then also for kids. That is the reason why we actually started the primary healthcare service with the chips, because it makes it possible to give like healthcare in these rural areas to kids and then also to mothers. So most of the money goes there, and then also some of the money also goes on into health infrastructure, because we know that once people are able to access the healthcare, they can get good healthcare. So we also have a chunk going into like building more like infrastructure. And then the other part also goes into health promotion and prevention, which is also a lot of chunk where we have a lot of community education on like health issues. yeah, basically that's what most of the investments are.
Okay. So in our case, it's very similar to Kenya, just like Yasser said. A lot of the money from here is directed towards vaccinations and prevention and healthcare promotion. This is the good part, but the bad part is, which was happening like a couple of years ago, but now it's gradually decreasing, is that, as I just told you, there was a government that was overthrown last year. So now the new government is better in terms of investing the money and finances in better and more useful places. For example, in the past, they used to put more money in the private sector, as in like build better private hospitals and better private ICUs and better private wards and like private medications and stuff, where people would go and pay money, meaning that the money would go back to the government in this case. But now the new government, like the new Minister of Health, is focusing on public areas more. It's focusing on improving the healthcare infrastructure. Like they're building new hospitals, they're building new research facilities. As there's a lot of tropical diseases present in Sudan, such as dengue fever and yellow fever and leishmaniasis and mycetoma, and a lot of the surrounding countries are relying on the Sudanese government to give them to provide them with research results and statistics. So currently this is the new focus, like basically vaccination, healthcare promotion, new infrastructure and statistics. But the bad part still is that still a huge part of the money going into building and rehabilitating the private sector that would form a good source of income for the government. But like I just said, they're actually realizing that this is not useful on the long term and they're trying to fix it. So this is basically it in terms of Sudan.
Okay, so the last question uh, is for everyone as well. What would you like to change in your country's health system?
Okay, maybe I'll go first. Uh, what I would want to change would mostly come from first, like from the top level. I would want more investment in the health system, because like I laid down a very nice structure of the health system, but the challenges mostly has to deal with money, and then also has to deal with education. So I would wish that like more investment is in the health system by the government, and that a lot of the health policies would strategize more on education, because as I said, many people would still not go to the hospital if they have like basic symptoms or like basic problems, but would try other like places, other alternatives, and then come the national health insurance will be like more than just the basic stuff, and then you can have like some intensive care, which is also covered by the national health insurance scheme, and that will be very good for the country.
I can go next. So if I was if I was given the opportunity, yes, I would actually change a lot in the health system. I mean, please make me the Minister of Health after this. Yes, I would love a lot of things from my personal experience as well. Is that accessibility? I'm really concerned about that. I'll give you a story of a patient, for example. The last patient I met before COVID struck in. This is a patient who had a dislocated hip joint. Yeah, he had a dislocated hip joint for over 1 month. Had no surgery done. It's not because he didn't care. It's because he was going from one hospital to another, and he was being referred to one hospital, and they keep telling him that we don't have space, we don't have space. And when they came to the hospital I was in, he was also told, sorry, we don't have space. This is a person who is in pain. this is the challenges that he's facing. He's really trying to, he's recognized that his health is an issue, but over 1 month he has no response. And there's several people like him. And if I was given the chance, I would actually first increase bed capacity. We really need high bed capacity for sure. And even I think COVID has taught us we need a lot of ICU bed capacities, because like I remember I was in this COVID, I was working with a lot of policy guys and stuff, and even consultancy with the MOH, and I just realized, like, in a whole Nairobi city we have only 8 ICU beds available for COVID patients, and that's scary, despite the numbers increasing. So these are some of the challenges I would really like to change: increasing bed capacity. 2, youth empowerment and youth involvement. I feel like there are a lot of old guys in the ministry, in the overall, who are running the health system. So we need more young people like me, or like so many other Kenyans, to have a voice in the ministry and to express their concerns. If it's education, more investments needs to be done in research, because we cannot have adequate interventions if you don't have to appropriate data. So we need more research, we need more funding, we need space for innovation, because during even this COVID time, we had some students who made up their own ventilators that were very cost effective. So students are really bright, so you need to give them an opportunity to innovate and change the healthcare system. So innovation, research, and something that I'm also passionate about, One Health, trying to make medical students work with vet students, or these students, even professionals, like different professionals from various career backgrounds, working together to improve health, overall health of the country. So these are the things that we need to change. Just not focusing health on just doctors and nurses and pharmacists and stuff, like involving also other stakeholders like architects or environmental health or scientists, just trying to broaden the horizon, because we cannot work in silos anymore, especially after what COVID has taught us. So yes, there's a lot I would like to change in my country's health system. It's not fair for a patient to go through to climb up the pyramid just to get good quality healthcare. We need to empower even the small community-based dispensaries to have CT scans available and stuff. I know the major challenge, especially I guess we'll all face, even Sudan or Ghana, is funding. But if you've got the right measures put in place, good data available, funding would not be a problem. Yeah, give me the chance and I will change the system. Thank you. Yeah.
Is he
So yeah,
breathing?
so just
Okay.
like Yasik just said, there's a lot of changes that need to take place in terms of the healthcare system in Sudan, in Ghana, in Kenya, a lot of African countries. And I think most of the problems root from the issue of financial. Sponsorships. Wrong 20% of the money to the private sector, and the population receive their healthcare services in the public hospitals, in the governmental hospitals. And unfortunately, these hospitals have a huge lack of support. In the whole of Khartoum, the capital city, there is maximum ventilators. And you guys can imagine the amount the federal ministry of health. So instead of investing a lot of the money and the sponsorships in private sectors, where these hospitals do not need any further rehabilitation, why not put this priority to the public healthcare systems. Number and perhaps the very prominent policies, very important and prominent policies in the Sudanese healthcare system is that children have the right to receive free healthcare services. As in, of course, this has been a huge burden on the Sudanese government over the past 5 years. So one of the ways in which hospitals, which are actually further developing and further increasing the problem. So a lot of the sponsorships and the funding needs to go towards the pediatric hospitals. And one last thing is also focusing on the research part, because Sudan has so much potential in terms of research and diseases and public health issues, but it's not getting enough attention in terms of funding, in terms of I think the moment is increasing the capacity of the beds in most of the public hospitals, because just like Yasir said like less than 2 minutes ago, a lot of the patients are randomly roaming around Khartoum and around different states of Sudan, trying to find one single empty bed to treat their child or to treat their mother or to treat their father, which is very much unfair because all of these citizens are paying taxes and they're paying a lot of things that they deserve to receive this treatment. And the government is not doing this on purpose, but there's a lack in capacity, a lack in proper planning. So, final thing that I want to say is that the healthcare system needs to reprioritize the issues and recategorize the problems that we're actually facing in terms of capacity, in terms of research, in terms of healthcare promotion, and in terms of proper funding and infrastructure. Thank you very much.
Thank you,
I want
Ibrahim.
to
I really
say,
like Go on, Monique.
sorry. Well, we have more questions, but we already passed like a lot of our time. So we will finish here the webinar today. And the questions, if you want to be answered, we can send you by a mail after, like just send on the name Instagram or even to them, like we tag them in the post. So you can always find any of them and send a message to have questions for your answer. I'm sorry to not be able to answer all the questions, but I mean, we're already here for 2 hours and a half, so most of people already left, and it's fine, and like I understand. And I want to say thank you for all of you to be here today, and to our guests. Thank you. You were amazing, all of you, and without you, we wouldn't make it happen. So thank you for support us in this idea. And I want to invite everyone to the next week webinar that is with EMR, so the Emirates version, and will be next Sunday on same time as today. So I will try to link here the promotional for I guess you see the promotional. And thank you for watching us today.
Thank you so much for saving some time to be here today. It was really nice sharing some background on your health systems and medical education, and for sure giving us different insights on different health systems.
Thank you guys too. I think this is a wonderful opportunity to share what we have with the world. And then we also wish the best for like DENEM. We hope to meet soon after COVID.
Yeah.
And then wait, everybody should come to Ghana and Africa, you know.
Thank you very much.
Also, thank you. Go ahead.
Go ahead.
Okay, go ahead.
All right. So I'd like
I
to
have connection issues, so it's getting late to me. So
I'd like to take this opportunity to thank Monique and Juliana. Thank you very much for having me on board and allowing me to express the system here in Kenya, and I hope this has been an enlightening session. It was also educative for me because I got to learn more about Ghana and Sudan, and I've seen that we have a lot of similarities within our region. So it was a really fun session. I wish it was longer so we could learn more. We could learn all the countries as well. Yeah, it's super fun and interactive. So thank you guys. Thank you, Bismarck, as well. Thank you, Ibrahim, for the amazing presentations. And we hope to meet hopefully after Corona ends. Yeah,
Yeah.
yeah. Thank
have
you.
to meet, man. We have to.
Absolutely.
Once again, thank you so much for DENEM Brazil, for Brazil DENEM, for giving us this amazing opportunity to present our healthcare systems and medical education. I really benefited so much from the Brazilian system at the beginning of the webinar, and then the Kenyan system, and of course the system from Ghana. I think Bismarck and Yasi did an amazing job. I'm going to be very frank. At the beginning of the session, I was thinking that it would be a little less interesting or more boring because I thought that, oh, how can healthcare systems and medical education be interesting and funny? But actually, and I really wish that if this webinar was, is there anything such as a physical webinar, if we were like all in the same place in like a GA or something? And I'd also like to take this opportunity to invite you all to come to Sudan. You guys have to come here and you have to meet up people from Brazil, Kenya, Ghana. Thank you so much. It's not going to be the last time. And also thanks for everyone who was watching us today. I really hope that they benefited and they had fun. Ma salama.
Thank you.
Thank you. Thank you guys for everything.